Priyanka Doshi, and I'm a pediatric psychologist who works in the Heart Institute at Children's Hospital Los Angeles. I've been here for 6 years and I work closely with our heart transplant team. I want to start off by thanking Melissa McQueen and this organization for inviting me to this talk. I'm so honored to be talking to an organization that does so much for pediatric transplant families. I am out of the country, so I'm sorry that I'm not presenting live. However, I appreciate the opportunity to record this, and my contact information is on the last slide if anyone has any questions. I don't have any disclaimers to report. Today, I will start off by talking about the importance of mental health for patients waiting for heart, kidney, and liver transplant. For majority of the talk, I will be talking about the pre-transplant period for all organ groups as a whole, while also acknowledging that there are differences between the groups. The talk will focus on symptoms of common diagnoses, what to look out for, and what makes patients waiting for transplant a unique group that potentially predisposes them to various mental health concerns. While the talk focuses on the patients, I will also talk about parent and sibling mental health, as family members are affected even differently. And finally, I will talk about strategies and resources to support kids and teenagers, both concrete as well as access as they cope with the transplant process. So why talk about mental health? The wait for transplant itself is stressful. It's filled with uncertainty, with things and thoughts like, will an organ ever come? What if I get too sick? How much pain will I be in? What will the long hospital stay be like? Waiting for transplant can cause emotional distress, such as anxiety and depression and trauma symptoms, but it can also impact physical health and post-transplant recovery and outcomes through things like non-adherence, missed outcomes, missed appointments, and higher risk of rejection. Development in life doesn't pause for illness. Chronic illness can delay independence, disrupt school and social relationships, and create feelings of being different, which can lead to mental health concerns like anxiety and depression. Family stress also impacts the child and vice versa. Untreated caregiver distress can also impact patient mental and physical health. Supporting mental health affects the whole system, not just the patient. Talking about mental health allows the kids and teenagers a voice and sense of control. It allows them to express feelings, learn coping skills, and focus on themselves and not just their medical diagnoses. And by providing holistic care, we're allowing children to live meaningful lives before and after transplant, in addition to dealing with their medical therapies and cares. By integrating talking about mental health at earlier stages, we are normalizing help seeking and decreasing stigma about mental health. Caring for mental health is not a sign that something is wrong, but that it should be a standard essential part of high-quality transplant care. Addressing mental health concerns early can reduce crises, improve adherence, and support better recovery after transplant. But most importantly, it helps children, teens, and families feel seen and understood during one of the hardest experiences of their lives. It's important to assess and treat mental health concerns. However, I do want to take a step back and really highlight that mental health concerns are a normal and expected response in children and teenagers who are in extraordinarily stressful situations. Mental health concerns can be understood as developmentally, clinically, and situationally expected responses as opposed to pathological reactions. Common emotions that patients might feel are grief, jealousy, either towards siblings or peers, guilt, anger, frustration, and ups and downs. I want to clarify that grief is a normal reaction. We sometimes see it as a reaction when someone passes away or dies, but really it's a reaction when we're coping with a change, a new diagnosis, change in lifestyle, and grieving what you thought your life would be like. Mental health concerns don't always look like sadness. As we will talk about throughout this presentation, these concerns show up as behaviors that often reflect an underlying stress or fear versus bad behavior. Children are still learning how to understand and manage emotions. Adolescents are navigating identity and independence in peer relationships. Chronic illness and waiting for transplant can interrupt these developmental tasks, making emotional ups and downs really common and understandable. The medical treatment itself and everything providers are asking for patients and families to do, dialysis appointments, medications, restrictions on activities, as well as the medical symptoms themselves, can also impact a patient's mood and behavior. And finally, normalizing does not mean that we are dismissing, it just means that we are acknowledging the difficulty that patients face while also supporting with building coping and resilience. As normal as it can be to experience mental health concerns, it is common to experience symptoms even if they don't always fit neatly into a mental health diagnosis. This will come into play as we review different diagnoses in a bit, recognizing that they have criteria, and sometimes patients have symptoms even if it doesn't meet full criteria. Also, symptoms can be situational and not indicative of a psychiatric disorder. Again, they can be normal reactions to illness, uncertainty, and repeated medical stress. These symptoms can change and improve as circumstances change, and symptoms can also change over time. Not all symptoms require a diagnosis. A child can experience anxiety or fear, sadness, or behavioral dysregulation without having a mood disorder. Also, it's important to consider that medical illness can often blur diagnostic boundaries. So, for example, things like sleep or appetite changes, or even concentration problems can be impacted by the medical condition or medical status. And so it's important to recognize that some of the symptoms might be more related to the medical condition than someone's mood. Mental health is also not binary. Symptoms exist on a continuum and can be dependent on disease severity, hospitalization, family stress, and other variables. That being said, focusing on symptoms does not minimize serious mental health concerns. When symptoms are severe, persistent, or impairing, formal diagnosis and treatment are essential and still require support. However, I do want to require some common diagnoses that we see in our pediatric patients who are waiting for transplant. Depression is when a patient experiences 5 or more of the following symptoms in a 2-week period, with at least one of the symptoms being sad mood or anhedonia, which means decreased interest in previously enjoyed activities. Additional symptoms include weight loss or weight gain, insomnia or hypersomnia, feeling slowed down, worthless or hopeless, fatigue, difficulty with concentration, and thoughts about dying. As you can see, these symptoms often overlap with medical symptoms, things like sleep or appetite concerns or increased fatigue. So it's important to look at the cognitive and emotional symptoms, if symptoms are disproportionate to medical status, and if impairment is beyond limitation. As you can see, like we talked about earlier, symptoms exist on the spectrum, ranging from just having a few symptoms to an adjustment disorder when someone experiences symptoms of depression directly related to an event but can remit over time, and a diagnosis of depression is given when the symptoms are more persistent and long-term. This slide reviews the prevalence of depression in pediatric patients waiting for organ transplant. One thing to keep in mind is that research in our pre-transplant population is limited when compared to research in the post-transplant population. However, in a study of 58 children evaluated before heart or heart-lung transplant, around 24% based on child report and 21% based on parent report had depressive symptoms above clinical threshold. And although there are no specific studies in liver transplant, we do see elevated depression scores in patients waiting for liver transplant. And similarly, children and adolescents with chronic kidney disease show higher rates of depressive symptoms than healthy peers, with studies reporting about 10 to 35%. That's based on age, disease stage, and how the symptoms were assessed. As we will discuss later, higher rates of depressive symptoms are linked to physical limitations, repeated admissions, uncertainty about transplant, social isolation, and school disruption. In liver transplant, this can be due to jaundice and other visible symptoms that make kids and teens look different. Sometimes patients might even have growth delays and feel different from their peers. And in kidney transplant, it could be due to dietary and liquid restrictions, as well as time-consuming treatments. Next, I'll review generalized anxiety disorder. Symptoms of generalized anxiety disorder include experiencing excessive anxiety and worry more days than not for 6 months. Other symptoms include restlessness, being easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. Again, you can say that some of these symptoms are close to symptoms of depression, but they're also close to symptoms of medical conditions. So diagnostic weight here should be placed on breadth of worry, perceived uncontrollability, which is also really hard in our transplant population, and level of functional impairment. There's a lot of words that we often use to describe anxiety that I thought would be helpful to review. Worry is repetitive thinking about possible problems and is primarily cognitive in nature. Nervous is a temporary state of heightened alertness, particularly before a triggering event, and often resembles feelings of excitement. Fear is response to a perceived threat. So, for example, parking in a dark parking garage, and that usually it can be adaptive and keeps us aware. And anxiety is a sustained state of apprehension and unease about a threat that has not or may not happen. So, for example, a little kid worrying that he or she might not get into college. This slide reviews the prevalence of anxiety in pediatric patients waiting for transplant. Around 14% of patients will experience anxiety before heart transplant or before their admission. There is elevated anxiety in adults waiting for liver transplant, and although there are no specific studies, it is presumed that pediatric patients waiting for a liver transplant also exhibit higher levels of anxiety. And for patients waiting for kidney transplant, around 35.2% of children had anxiety symptoms, with 10.5% of those being anxiety alone, and the other 24.8% having both anxiety and depression. Again, anxiety is impacted by fear of procedures, fear of death, fear of worsening of illness while they wait, and just dealing with the physical symptoms themselves. Many of the symptoms of the disease can also mimic symptoms of anxiety, and there's also anxiety related to growth delays and social isolation. Our patients are also at higher risk of experiencing post-traumatic stress symptoms and post-traumatic stress disorder. While providers and staff work in a hospital and see these procedures or are giving bad news or new diagnoses all the time, it's their job. This can be a patient and family's first experience. That being said, not all patients who undergo surgeries or invasive medical procedures have PTSD. What is traumatic for one patient may not be perceived as traumatic for another. Trauma symptoms and disorders also exist on a spectrum. Someone may experience a stress response, which is an acute distress in response to a perceived traumatic event, which can be considered normal and adaptive, and then return to a normal emotional state. Patients may also experience post-traumatic symptoms, which are a set of physiological and psychological reactions to traumatic experiences without meeting criteria for PTSD. Someone's given a diagnosis of acute stress disorder when they're experiencing the symptoms from 3 days to a month, and a diagnosis of post-traumatic stress disorder is given if these symptoms are existing for longer than a month. Again, this shows that even if someone doesn't meet criteria, the symptoms can cause impairment and increase the need for psychosocial support. Symptoms include intrusion symptoms, so things like distressing memories or nightmares or flashbacks. There's avoidance of external and internal reminders. There's negative alterations in cognition and mood, so things like forgetting moments about the traumatic event, negative beliefs, blaming self or others, having negative emotions, and decreased interest or detachment. There's also alterations in arousal and reactivity, so increased irritability, reckless behavior, hypervigilance, startle response, sleep difficulty, and difficulties with concentration. Around 34 to 43% of heart transplant candidates experience trauma symptoms, even if it does not equate to a diagnosis. In a study that included liver and kidney transplant candidates, around 13 to 22.6% experience post-traumatic symptoms, again, even if they don't meet diagnostic threshold. What we do know is that pediatric transplant patients are at elevated risk of traumatic stress due to chronic illness, frequent medical procedures, hospitalizations, and uncertainty. So now I'm going to transition to talking about mental health concerns during the evaluation and listing process. Once your kid is referred for transplant evaluation, here are some strategies to help prepare them for what can be a long appointment and a long day. First, the evaluation from a psychology and social work perspective is to really get to know the families, to provide recommendations and resources, and to establish early relationships to provide support throughout this entire process. For younger kids, it might be helpful to let them know about the evaluation by giving them basic information, such as doctors are thinking of ways to help your body, and one way is to see if your body is ready for a new heart, kidney, or liver. It can often be helpful to use visuals or drawings to talk about transplant, to give them choices. So, for example, what to bring, activities they can do if there's parts of the evaluation that might be too hard to hear, and also preparing them for what tests and things will be done during that day. Some centers will have child-led specialists who can also be available to help patients navigate this evaluation process. For adolescents, we recommend honest and transparent discussion, uh, how long the process takes, what recovery and life at home will look like, so things like restrictions, sports, and social life, and keeping them involved in the decision-making process. There is a huge emotional impact of waiting for transplant once listed. There is so much prolonged uncertainty. There's no timeline of when transplant is going to happen. And so in many cases, families are on high alert, just waiting for the call. The specific symptoms associated with a chronic illness can change over time, things like fatigue and pain that significantly can impact mood, especially as they notice that it becomes harder to do things at school or harder to do things that they previously enjoyed. Medical visits and admissions leads to time away from school, which can impact learning and grades and miss social opportunities and make kids and teens feel really left out. Family functioning is also impacted. Parents have increased in caretaking stress, which can impact their own mental health. Additionally, in adolescence, we might see that parents are understandably more overprotective while adolescents are trying to be more independent. So this can affect family relationships. And siblings are impacted as well, like we will talk about later. And finally, there's also physical differences, things like scars, different equipment, catheters that might make teens especially experience body image and self-esteem issues. And then when the call happens, it is normal to experience strong emotional reactions, things like shock or anxiety, crying, feeling like your mind went blank, guilt, feeling scared. And there's also the mixed feelings of also excitement that something you've been waiting for is finally here. Teenagers might fear death, have more body image issues, and have a desire to back out. Kids might feel more confused and fear of separation from their parents or caregivers. All this to say that strong reactions are expected when the call happens. And as we have slowly been referring to, what we're really seeing is that developmental milestones are often hard to meet or delayed when we are talking about kids and teens who are coping with chronic medical conditions. As you can see, 0 to 5-year-olds are starting to follow rules, taking turns, learning basic skills, are curious about their world. 6 to 12-year-olds are more modest about their body. They're starting to value friendships. They're starting to think about their future. 12 to 14-year-olds are experiencing body image issues, peer pressure, moodiness, conflict with parents, and increased focus on self. And 15 to 17-year-olds are experiencing more thoughts about independence, romantic relationships. They're viewed as self-absorbed. They're spending more time with friends, and there's a lot of risk-taking. And being in the hospital and dealing with medical stressors, even on an outpatient basis, can often deter, block, or delay these milestones. Being in the hospital means that everyone is moving on without you. You're watching your friends do things and you're missing out on learning, which can affect academic progress. It's hard to maintain independence when you're dependent on a family or team members to provide cares. You lose privacy in a hospital when people are entering the room and engaging in doing all these cares. You experience body image issues when you have scars or bruises or tubes. And you feel different when you're not able to do things that you previously enjoyed or everyone around you is doing. And so when these milestones are deterred and delayed, it predisposes many of our kids to experience emotional and behavioral difficulties. And so therefore, kids and teenagers will present with emotional and or behavioral concerns differently at different stages. During the toddler stage, you might see increase in tantrums, limited emotional expression, regression of skills, so things like bedwetting, separation anxiety, regulation difficulties. And you'll see some of these things in kids who are 4 to 11 as well. Bedwetting, clinginess, somatic symptoms, irritability, avoidance of school or social activities, emotional outbursts, difficulty with peers. And in teens and adolescents, you might see withdrawal from friends or activities, changes in sleep, increased conflict with caregivers, irritability, academic disengagement, self-esteem, fear of death, frustration with lack of independence, and risk-taking concerns about the future. Symptoms should not be looked at in isolation, so 1 or 2 of these things does not mean that something is wrong, but it's important to look at context. Are these changes? Are these new? To get more insight into what is going on with your child or teen. In addition to patient mental health concerns, we have to consider the system. Parents are also prone to mental health concerns as they navigate a medical system and are experiencing their own grief for what they thought their child's life would be like and what their life would be like as a parent. Looking at this diagram, we can see that stressful experiences of a new diagnosis, long hospital stay, medical complications, and even financial and logistical stress can lead to thoughts of feeling hopeless or helpless, feeling guilty or responsible, feeling alone, and a lot of uncertainty, which can lead to anxiety and depression and traumatic stress. And we know that parent mental health can really impact a child's emotional and mental health as well. And so ways to mitigate it is for parents to seek out their own support, whether that's through social support, joining groups, talking to families with similar experiences, reaching out to social work, and getting your own therapy or counseling. However, just as it is normal to experience mental health concerns as patients, it's normal for parents to experience their own stressors. There's anxiety about the call, hypervigilance to medical symptoms, relationship strains with increased focus on patients, depression, and feeling helpless, vicarious trauma to watching your kid and teen go through stressful medical events, chronic stress and burnout, which can affect sleep, guilt and self-blame, and the moral distress in awareness that a donor's death can be required for child survival, and conflict between gratitude, grief, and hope. And we also know that it affects sibling functioning. Siblings are impacted when their brothers or sisters are spending time in the hospital, the stress of not knowing what that means or what's going to happen, the guilt of why not me and what did I do something wrong, disrupted family dynamics. Sometimes siblings are cared for by extended family members or are sharing their parents with siblings, and that can lead to sibling jealousy on both sides, as well as sibling loneliness. Some siblings feel like they need to increase their responsibility and grow up faster than they need to. And a lot of the uncertainty of, is their sibling going to come back home? So now I want to transition and talking about what can we do? What can parents do to help support kids and teens as they navigate this journey? In general, I always recommend having open and honest communication, but in a developmentally appropriate fashion. Parents will frequently ask about what to tell their patients and kids when they're listed for a transplant. I always recommend open and honest discussions because kids overhear things, whether they're in the hospital or for outpatient medical visits. And this often leads them to make up their own stories and do their own research on Google. And it is safer when they're getting the information either from the parents or medical team. You can always tailor your language and reach out to child life and or psychology to provide information. But examples of things you can say are, your liver is sick and you need a new liver to feel better. Kids will always ask questions when they are ready to know the answer. It just takes everyone different amounts of time to process the information. By not hiding the information, you're preventing them from feeling that this is a big, bad, scary thing, which it is, but you're keeping the door open for them to ask questions and to talk about their thoughts and feelings. It is okay for everyone in that discussion to feel scared, but having the discussion versus shutting them down can promote healthy and adaptive coping during the preparation stage. In the same vein, being honest does not mean promising that everything is going to be 100% fine while you're also trying not to scare them. So I recommend staying away from strong declarative statements such as you will for sure be fine, and saying things like the doctors are going to work really hard to keep your body safe and strong. You want to use simple and clear language so that the kids really understand what they're being told. And during this waiting stage, you really want to maintain structure and routine as feasible and recommended by your team. So going to school, keeping family rituals, keeping friendships so that they see that their parts of their life are normal, even while they're waiting for this new organ. Something I always recommend is teaching coping skills, even if kids are not presenting with signs of mental health concerns, so that if and when things get harder, they have them in their toolbox. Also, sometimes differentiating between active listening versus problem solving. Sometimes teenagers just want to vent and express their feelings without feeling like someone's going to do something about it. And so it's okay to ask, do you want me to just listen or do you want me to solve the problem? Because that can go a long way in maintaining open communication. And finally, we want you to model talking about emotions and help-seeking behaviors. So you're letting your kids and teens know it is okay to talk about emotions and it's not something to be avoided. How to prepare for the call. You want to talk to your kids and teens in advance about what might happen. So giving them information about what to pack, what to expect, giving them control and choice. So like packing their own bag, how they want to decorate their room, comfort items. And sometimes I'll work with child life specialists to help prepare patients for what to expect in the admission and waiting for the transplant. You want to discuss and have conversations that it is normal to have mixed and multiple feelings, gratitude, grief, and fear. And for teenagers, you want to talk about addressing fears about surgery, recovery, and discussing body changes that might happen so that things are not a big surprise when the call happens. And what to do after the call or on the way to the hospital. Take a few moments to regulate your own emotions and use your own coping strategies when you get the call before talking to your child. Talk slowly, take deep breaths, speak calmly, and avoid big catastrophic statements. Kids co-regulate and will regulate their emotions based on how you are regulating your emotions. That means if you need to take a break and hide for a few minutes before you talk to your kids, it is okay. You want to give honest but contained information. For kids, you might say, the doctors found a new heart, kidney, or liver for you, and we're going to the hospital so they can check if it's a good match. For teens, you might say, it's okay to be scared. We don't know everything yet, but the team will walk us through it. And again, we want to avoid saying that everything will be fine for multiple reasons. It minimizes their emotions, and unfortunately, there can be risks. So it could be helpful to say instead, the doctors are very experienced and will take very good care of you. Teenagers may experience, and even kids may express fear and ambivalence and say they don't want this. Remember that it's fear, not refusal, and to validate their emotions and to bring up their concerns to the team instead of shaming, minimizing, or threatening. Ask for psychology, child life, and social work support. And finally, it is okay to prepare them for the possibility of a dry run, and you can normalize this process as part of the transplant process and remind them that this does not mean you won't get another call. These are some examples of how to provide validating responses. If a kid says, I'm scared, for example, an invalidating response might be, calm down, or you have nothing to be scared about. Validating response might be, I can see that you're really worried. If a kid says, it sucks to have a heart condition, an invalidating response might be, you should be grateful for all you have. A validating response might be, this sucks and it's okay to feel this way. How can I support you? If a kid or teen says, I can't do what everyone else is doing, an invalidating response might be, at least you're alive, or I know what that feels like, or yes, you can, you just don't try. A validating response is, it makes sense that you feel that way. I can see that this makes you upset. Things to be mindful about. These are not hard yeses or no, but things to consider. Calling your kids strong or brave for some other age. I have been guilty of doing this, but sometimes I'll have kids remind me that it's not fair that they have to be this strong and brave in the first place. And this is something that they were doing a long time ago. Saying I know how you feel can really minimize and invalidate a patient's experience. We can understand and see, but we might not know what they feel like because they are the ones being prodded and having to go through all the medical interventions. We want you to express your worries and feelings, but not putting adult worries on them. So, for example, letting them know how expensive this process has been to prevent them from feeling guilty or that they are a burden. A big one is reacting versus responding. Oftentimes, when kids and teens feel big feelings, they might say big and scary things that initially might make parents want to yell and shout and say, don't do that. But if we take a moment and respond calmly, it might maintain open and honest communication between you and your child. We talked about not invalidating emotions, and finally, guilt parenting. I have many parents who say how bad they feel for everything that their kid has gone through, and that is such a valid emotion. However, part of this whole transplant process is to live a normal life as possible, and that also includes setting limits, having boundaries, and giving them rules. It also maintains normalcy between siblings. So now I'm going to talk a little bit about how therapists can be helpful. As I mentioned earlier, we'll sometimes just review basic coping skills with all patients and families so that they have these skills in their toolbox if they notice that anxiety or other big feelings are popping up. These help to activate our body's relaxation response, and they help to refocus on the present moment to distract from anxious feelings or when someone's feeling overwhelmed. There's using our senses to ground ourselves, so identifying things that we can see, touch, hear, smell, or taste, or things you like about yourself if you're not able to eat or have restrictions. There's rainbow grounding, where you're using the colors of the rainbow to identify different objects around you. And then deep breathing. These are also different types of therapy that you can be on the lookout for. Cognitive behavioral therapy is a type of psychotherapy that helps people manage their thoughts and behaviors. It helps people recognize unhelpful thinking patterns and to reframe negative thoughts in a more logical way. And this is really effective for things like anxiety and depression. Trauma-focused cognitive behavior therapy is an evidence-based therapy that's geared towards kids and teens who have experienced traumatic events, so things like post-traumatic stress disorder or even post-traumatic stress symptoms. Behavior management training is a type of therapy that aims to change maladaptive or unwanted behaviors and uses principles such as positive or negative reinforcement, punishment, and extinction to increase positive behaviors. There's different forms of these therapies, such as parent-child interaction therapy or child-parent psychotherapy, and this is helpful for kids who might be experiencing behavioral difficulties, things like ADHD or noncompliance. Motivational interviewing is a client-centered, evidence-based counseling approach that aims to help individuals explore and resolve ambivalence about making change in their lives and can be helpful for things like non-adherence. And acceptance and commitment therapy is a type of mental health therapy that helps people understand and accept their thoughts and feelings and to adjust their behaviors to match their values, and is really helpful in older kids and teens coping with a chronic medical condition. Finding a therapist can be hard, but these are some different strategies. Things like calling the number on the back of your insurance card and having them give you a list. Different websites like Psychology Today or Rula, Headway, or Good Therapy. If your child is a regional centers patient, asking the service coordinator, talking to your team's social worker or psychosocial support team, pediatricians, school teams, and different websites that are listed here that will also be in the resource bank. There's also different resources that you can download or different apps, things like Headspace, Insight Timer, the breathing app, UCLA Mindful, Breathe, Think, Do with Sesame, Smiling Mind, Go Noodle, Cosmic Kids, and Calm app that have different strategies to help with calming big feelings. And you can also find various clips of these on YouTube as well. In conclusion, waiting for transplant is unpredictable and can affect the entire family system. It is normal to experience mental health concerns in the context of waiting for transplant. Incorporating psychology at the onset of medical appointments and integrating them as a part of the team can normalize mental health. And therapy is helpful in developing healthy and adaptive coping strategies, regardless of if the patient's experiencing symptoms, diagnosis, and just for general support. Thank you so much for having me in this talk. Here's my email that you can reach out to me if you have any questions. Thank you so much.